The most important thing in my mind to think about would be that immunotherapy is now an option for many patients with many different types of cancer. Just 10 years ago, there were really there's one immunotherapy FDA approved for two cancers, at least for metastatic cancer. And in the past decade, there are now 3 anti-PD-1 antibodies, 3 anti-PD-L1 antibodies, a CTLA-4 antibody, a number of combinations of those, and other combinations with chemotherapy, and more recently, anti-angiogenic therapy. I think the message is we're getting there. And the most exciting thing about immunotherapy always was the idea that this could potentially inspire your body to get rid of your cancer. And we're now doing a better job of that. I think the second part, so the second most important thing to tell people would be that we're not there yet for every patient. And so unfortunately, we still have a long way to go. And that's the thing to say, but then the other part of that phrase is, but we're making progress. Mm-hmm. And one of the things that we'll be talking about today is some of the new approaches to targeting various other targets in combination with some of these new immune therapies to allow them to work better for more patients. The immunotherapy crowd has been very excited about immunotherapy for 10, 15, 20 years. There were a number of trials that were done with dendritic cell vaccines and cytokines that didn't really work for most patients and didn't really work by and large in many different cancers. And so there was a general feeling that immunotherapy wasn't a very effective strategy to treat cancer. What I would tell physicians, although you don't have to tell many oncologists now, is that that was wrong. We just didn't know how to give immunotherapy. We didn't have the right tools, we didn't have the right drugs. But now that we have the right tools and right drugs, we're really making substantial progress. So what I would tell, or the key takeaways for physicians is the era of immunotherapy has arrived. We are making great progress in a number of different diseases. We are continually iterating off of our advances and learning why drugs work, why drugs don't work, and then based on that, developing new therapies for patients. We're getting better at figuring out which patients we should be offering which therapies to. And then finally, we're also getting a better understanding of toxicity. And it's really critical for physicians, no matter what your discipline is, to know that immunotherapy is out there, it's potentially effective, it's potentially curative, and it's potentially very toxic. And so we are working really hard as a group at MGH and across the country and the world to get better at understanding why people develop toxicity and then try and figure out how to minimize that toxicity without minimizing the potential great effects against the cancer that the immunotherapy is creating. MGH is a remarkable place. About 2 years ago, we had a patient that had a terrible outcome with immunotherapy. And in conversation with his family and in conversation with providers to help care for him, we decided we wanted to do something. And we weren't sure what that something was, but then as we thought more about it, we realized that what we should be doing is creating an inpatient service where the people who are the most expert in oncology and immunotherapy would be seeing those patients, and more importantly, the people who are the subspecialists that were most interested in caring for patients with immunotherapy toxicity would come together and really be aligned in efforts to better the care of these patients. And our tireless leader of our inpatient service, Carrie Reynolds, went to the administration of MGH and said, we need to do something, and this is what I propose. And the administration said, yeah, it's a great idea. And they provided support, and they've allowed enough startup to get going. And then because of the nature of the place, because there are people that are interested in caring for patients better and learning how to do that, we have a group of 30 or 40 people that meet every other week. We have a translational infrastructure that is allowing us to better understand why these toxicities happen, who they happen in. And we've really are at the forefront in the country and the world at learning about these types of toxicities and improving the outcomes for patients. We were the first hospital to have an immune therapy service for toxicity. We call it the Severe Immunotherapy Complication Service. But now people ask us, they come to me and they say, what should we do? We want to do this. And I say, talk to Carrie, because she really knows. And I just was there while she was doing it. And it's you know, an amazing opportunity to work in a place like this, that there's an idea based on a patient-specific problem. We realize that that problem is not just individualized for that one patient, but is shared across many. We know that if we learn more about it, we can be better at caring for patients, and then we can ask our colleagues, ask our administrators to help us do something about it, and they do it. There are very few places that would have just out of the blue said, let's do this. Mm-hmm. Once somebody does it, others will say, oh, we should be able to do that too. And my hope is that this continues to be a trend all over the country and over the world, that we're able to really learn about this in the collective, not just at Mass General, but I know based on the support and the interest from everybody involved in the investment, just the time and effort, intellectual investment and some financial investment, that we're going to get there.